Welcome to Performance Matters Live. Today we're talking about leading with love to improve the human experience in healthcare. As many of you figured out, this is a topic applicable beyond healthcare. So welcome to the many industries and backgrounds that we have joining us today. We're thrilled to have you. In terms of the experience today, we will be recording the conversation, so no worries if you miss anything or have to drop early. We'll email that out to everyone who attends. Feel free to sit back and listen, or we invite you to use this as an opportunity to connect with others. So we welcome you to introduce yourselves in the chat. Just be sure to change that chat setting to panelists and attendees so that we can all see your posts. And feel free to add your LinkedIn address if you'd like to connect with others who are on the call. Lastly, we welcome you to add your voice. So if you have a different way that you would respond to a question or thoughts on any of those, drop those in the chat, and we hope to have some time for Q&A at the end. So you can either use the Q&A feature or drop those in the chat as well. For those of you who are already friends of Tier 1, welcome back. We're so glad to have you on the call today. For those who are new, just a little bit about Tier 1 performance in Tier 1 healthcare. We activate strategies through people. So whether that's your patient experience or customer experience strategy, if you have growth or transformation strategies, and as well as talent development, all of those we help look at the people factors that either might be barriers or can be amplified to allow each of your team members to bring their full potential to the table and bring that strategy to life. And one of the things we're seeing a lot of is this intentional design of how we work together. So new ways of working as we transition out of this past year into really being intentional in how we show up in terms of team dynamics, leadership, ways of working. And that's so relevant to the conversation today. So I just want to thank our amazing panelists and thank them for their time and being part of this discussion. Thank you, Carol, Ron, Barb, and Richard. And a giant shout out to Carol, who very recently retired. So congratulations to her. And so without further ado, I'm going to turn it over to Richard to get us started.
And Richard has turned on his microphone. So good morning, Sarah. Thank you so much for those opening words. So folks, we're going to dispense with in-depth introductions today and simply jump into the conversation. However, I also want to add my personal thanks to Carol and Bob and Ron for your time and energy today. Thank you so much, guys. These three colleagues and friends are living proof, folks, that when you lead from a place of love and authenticity, it makes a difference in the lives of others. Not only does it improve outcomes like team engagement, staff and patient experience, lowers turnover, it also fosters creativity and innovation. It supports the courage to speak up, and it actually encourages ways of thinking and experiencing work differently and ultimately improving the care that we deliver. So as Sarah said, as we emerge from the pandemic that has, quite frankly, gripped our world, changed so much of how we think about and approach work, especially in healthcare, this invitation to be vulnerable and to be loving as we lead, we think is timely, and it's a critically important one. And if you believe, and I think you do because I know a lot of you, as we believe that those that you lead can't give what they've not received, then now's the time to show up as a more authentic and, quite frankly, human leader. I have a good friend, Steve Farber, who recently published his latest book. It's called Love is Just Damn Good Business. And he shares this terrific point of view about the difference between vulnerability and what he calls the pretense of invincibility. And he says vulnerability aids human connection, and connection is actually the conduit for energy. The pretense of invincibility builds walls and creates distance between human hearts. it's with those words that I'd like to get on with this and build some connections between all of our human leading loving hearts. So Carol, before we jump in with the first question, when we asked you to share your loving leadership walk-up song, can you share with everyone on the call today why it is that you picked Whenever I See Your Smiling Face by James Taylor?
I would love to, Richard. And thank you so much for this invitation. This is such a delight. I chose that song for two reasons. Number one, I think a genuine smile is one of the ways we show each other love. And when I see your smiling face, I have to smile myself. And I think that contributes to this culture of love. So I love that song and I love James Taylor. But the second reason I chose that song is because I sing it to my grandchildren almost every day. So it's just a very special song for me. So thank you for
Thank
asking.
you, Carol. So Carol, when you hear this phrase, to lead with love, what does that look like for you? How do you show up with that in mind?
So my career really has been focused on patient experience and employee experience. I believe it's about the culture that we create. And so when I think about leading with love, I think it's absolutely imperative because without it, we don't have the culture where everything works the way we want it to work. So I did a lot of leadership teaching, if you will, or sessions on the importance of leading with both strength and empathy. In my opinion, you cannot have one without the other and be a good leader. You need the strength so you're crystal clear about what's important to you and to your culture. And you need the empathy so that you can be present for your teams and show them that you care about them. As you said, Richard, they can't give what they don't feel. So it's all about creating this culture where both really are strong, both strength and empathy.
Love it. Thank you so much, Carol. When Ron, when we asked you for your, and for those of you following along at home, we asked the panelists to give us the kind of leadership love walk-up song. I don't think I've ever seen someone respond to an email so fast as Ron did. And Ron, can you share with everyone why you picked Stevie Wonder's "Love's in Need of Love" today?
Yeah, so thank you, Richard, and to the other panelists, thank you also, and for everyone that's on the call this morning. So I suppose, like Carol, I'm a big Stevie Wonder fan, first of all, but this particular song over the years has resonated with me, and it specifically resonates with what I've seen in my over 30-year career now in healthcare. That is so easy for us to drift away from what we originally set out to do. And it expresses itself in ways that people feel. It expresses itself in ways that um, um, do harm. And a person, a family, a patient, or even a community can walk away from us as caregivers thinking we are not liked. And in some cases, people feel like they're hated. And it could be because of their race, ethnicity, gender identity. It could be because of a disability or physical or cognitive. It could be because of their size. And I have so many stories over the years, and I'll be brief, but yeah, I encountered one person at a conference where we talked about some of why we don't care, why we take people's dignity from them, why we don't show compassion and empathy. And she had gone through a significant weight loss. And she said, the healthcare givers and other people now treat me differently than they did when before I lost weight. They didn't care about me then. I didn't have friends. And this is a healthcare professional who was at this point now tears meeting under her chin. So when I think about that song, I think how easy it is for us as caregivers who say we are here to serve people. And I was on admissions committee at a major medical school. When you hear applicants to medical schools answering the question when I ask, why do you want to be a physician? And they say, because I love people. So then what happens in a system that they drift away from their original intent to love people? That in some cases translates to disrespect, unempathy, lack of compassion, and taking people's dignity away. It's like one young man said once, I don't have a physician, I have an accountant, because the person doesn't see me. So I'll stop there, could go on, but that a lot of that comes up when I hear that song, particularly right now in the throes of all the social unrest and the upheaval in the healthcare industry because of COVID and the outcomes for again marginalized and under-resourced communities because of COVID, but existed pre-COVID. So to me that means maybe we didn't love people pre-COVID, and now we're trying to understand why they're suffering. They were already suffering because we didn't love them then. So I'll stop there.
No, I appreciate it, Ron. I appreciate that insight, man. Pivot, Ron, if you would as well, my friend, and talk about what it means for you. And you've had this kind of crazy, unique career, both here in the US and overseas, and regulatory space, operations space. What does it mean when you show up as a leader to lead with love? You've spoken about
Yeah,
some of the stories. What does that mean for
sure.
you as a leader?
So what it means to me and every place I've been is when I go into meetings or conferences and people talk about tools, they talk about methods, they talk about standards, they talk about regulation, and policy and guidelines. And it's all too often, even now, that I have to say, wait a second, we're talking about people. We have to put the people in the middle of what we're talking about here. And what does that mean then? That's a servant's heart, right? And I refer to it as heart work. Heart work is love work, right? As opposed to saying, well, Ron, it's hard work dealing with patients and families and yada yada yada. But it's hard work. And we cannot marginalize the reason that we say we're here in the first place, to give care and to provide service.
I love it. Thank you, Ron. And as you're speaking, I'm seeing Bob and Carol's faces, and I'm seeing Bob's doing this nod. Um, Bob, you picked for your song one of my favorites, so I'm a little biased, but "All You Need Is Love" by the Beatles. Can you give folks a glimpse into why that, and then feel free to segue into what it means to you as you show up every day as a leader to lead with love.
Sure. So I gotta say first, Ron, are you still taking patients? Because
I,
that's
I, I'm not. I do miss it though.
yeah, because I'd be wanting to sign up. Let me just tell you. All you need is love. You know, the Beatles, what can you say about the Beatles? They have such simple messages, right? We all know the words, we can sing along, but they're so poignant. Like, they get to the heart of a message in a way that complexity really can't. You know, you can just understand what it means. And fundamentally, to me, I think about, we as people, we have a universal experience as human beings, and we all do need love, right? That's what makes us tick. That's what makes us feel whole. That's what connects us to the earth, to our spirit, and to each other. So that's why I love that Beatles song. And so transitioning that into what leading with love means to me, love implies a relationship. So to me, it's about the relationship that we have with the people that we work with, not just those that report to us, but those throughout the organization. And the characteristics of that relationship, as Ron mentioned, and Carol as well, have to be people-centric, right? It's about caring for that person that we work with as a human being first, before we think about productivity or the work that we're doing. And I tell you, I made a mistake for years in my career, thinking if we just all got to it and got our heads down and got busy, that things would be better, we would achieve our goals. But what's the fun in that? right? Right? We really, that connection is what makes, it's what makes work fun. It's what makes us excel. It's what makes us problem solve better. So that relationship to me has to have some characteristics that are fundamental to achieving great relationships and creating a great work environment. And that's respect and trust. And I think that builds a foundation where we can grow and there's strong accountability. Now, those are simple words like the Beatles songs, but they're hard to achieve and they're super easy to lose. And I want to give one simple example. And that's, think about respect. And I'm going to take us to a meeting room. And we're in a meeting and people are sitting around the table and they're at all different levels. And I would ask the question, does everyone at the table have an equal voice? Or is it just those in the most powerful positions? If someone is giving a presentation, is everyone paying attention and engaged, or are they texting on their phone? Those little nuances make a huge difference and set the tone for the culture and for the organization. So to me, it's really about paying attention to the feelings that people are going to get from the actions that you take.
I love that, Bob. I love that reflection on it being, the simple words or the simple things that we can remember, and yet awfully complicated, and one could imagine complex actually when it comes to delivery. Shift gears for me a little, panel, and I throw this out to all of you. And Ron, you touched on it, about this notion of kind of where were we, or what were we, or how we were leading pre-pandemic. But how have the events of the last, let's call it 18 months, guys, changed how you think about work or leading? And what are you taking away from that experience that is perhaps a gift or a pivot or a reminder that is different than where you sat 18 months ago? What's the thing that the last 18 months have given you as a leader?
So I can lead if you like.
Awesome.
As you know, my work is in patient safety and quality improvement. I always think back to Avitas Donabedian's work that we all have to know. And there's a quote from Donabedian that I think we all should believe in. The work that we do is a sacred mission. It's a sacred mission. So what COVID has shown us is we have drifted away from that sacred mission. It could be a revenue mission. It could be a reputation mission. It could be a power and authority mission. It was not a sacred mission. And then somehow leaders are surprised that, oh my goodness, that their mortality rates are so high for populations. Oh my goodness, we didn't have the proper supplies and equipment needed, or the staffing levels needed for systems and hospitals that were providing service to communities that were under resourced and marginalized, as if now is a surprise. The problem with that, in my opinion, is a lack of love and care and empathy and compassion and respect for those communities. Therefore, what happens? We forget the history of the contribution that the people and the communities have made for us. They work in our systems. So in some cases, without a living wage. To not pay a person a living wage, to me, lacks love and respect. And that means that to something that Barbara said, in many cases, people and populations have been devalued, if not dehumanized. When we decide we're going to unequally allocate resources to some places and not to other places, that is a lack of love in my mind. That is a love of disrespect. So then we say, oh, we're surprised that the death rates are what they are. We're surprised that these things exist. They were pre-existing conditions, as I say. The canary in the coal mine was already on life support pre-COVID for some populations. That means that did we love those people initially? Were they part of our sacred mission to care because we are caregivers? So I think as we think about pre-COVID, mid-COVID, where we are now, and what happens next, what will be next, and can we now take these lessons learned and in some cases go to a community or people and say, we failed you, I apologize, I'm sorry. If you love a person, you can do that. You can say, I value you, I failed you, I am sorry, but here's what we're going to do now to show you that we love you, and we're not going to drift away from it again. And if you see a drift, we want you to tell us, and we will humbly listen and act. All of that is love work. So anyway, I get carried away, Richard. You know I do, but I'll stop.
I love it, man. I feel like I'm in church, Ron.
Oh,
Carol,
yeah, I'm ready to explode. I could not agree with you more, Ron. I think you have said it so eloquently. And I also, when you first asked the question, Richard, I thought to myself, it isn't any different, but our awareness of the need has been raised. We see our teams of people, both our communities of people, as you've talked about, Ron, and also our healthcare workers totally exhausted. They are exhausted. And so it makes this awareness of the need to meet them where they are and show them love and empathy and compassion. It just raises that awareness for me. But I think it's always been there. The need has always been there. And for me, it's about the culture that we create. We cannot do anything, whether it's patient experience, safety, quality, continuous improvement, treating each other with respect. We can't do any of it unless the culture that we have created and we continue to sustain is one in which we really do show love to each other. So for me, it's just this heightened awareness of how important this concept really is. And I think that if we can leverage what we've learned during the pandemic and continue to work on that as a focus, I think we'll be all the better for it.
thank you, Carol. Bob, any thoughts?
I'll just add to it. I think the pandemic gave us a glimpse into the personal lives of people that we maybe hadn't seen in the past. So, we got to really see the pain and the suffering up front and personal. You can't ignore that, right? With what went on or what's in some cases still going on. So I think that helps us recognize, or hope that that's helping us recognize how we need to address things differently as we move forward. We're going to be forced to. I mean, with the taking hospitals as an example, with the turnover and the high vacancy rates that exist, the problems that we're facing are going to be for the long term. And addressing those with love, with looking at the individual needs and addressing those needs is going to be necessary. Otherwise, we won't succeed.
I love that, guys. I'm going to shift gears a little, and I am privileged, and I mean that in the most intentional way, to know each of the three panelists today really pretty darn well. And you've already heard them share some of their beliefs and their philosophies and their thinking. This is how they show up. So this is not, they're just on screen today doing this. This is who they are. They are vulnerable leaders. And the question I want to pose to each of you as you think about, and Bob, I've seen you do this, right? And I've seen you sit in that conference room and say, hey, are we all paying attention? Are we all listening to all voices? Are we taking everything into account? How, or maybe what are, in your experience, Carol and Ron and Bob, some of the barriers to being what I would call emotionally vulnerable, kind of being yourself in the workplace? And it's one thing to, get home and do it in the privacy of those places we've been sitting for many of us. So as Ron says, I ain't going anywhere soon. What are some of the barriers to being your whole self as a leader in our places of work? Some of which you've alighted on, but just give us a sense of what some of those barriers might be.
I'm happy to.
Oh, go ahead, Barb, you start.
Okay, sure. I'm going to say, as I've grown up in healthcare, when I first started in leadership, the definition was about command and control, right? We organize, we command, we control. We're expected to know things, be the person who can direct. And so I think our history has set us up a little bit to not. So I think we have to really get beyond that. So, I think in the past, knowledge was considered power. Actually, there's a saying, right? Knowledge is power. So keeping the knowledge within one person or a group of people has, again, in the past been considered the way to go. But I would strongly say that's probably not the way to go. That I would say it's the opposite, that it takes a lot of courage to be vulnerable. And it takes a lot of courage to trust that your team has the strength, give them the strength and share that power. I think that to me is what makes a difference in an organization and starts to change that culture. So to get there, this point of vulnerability, I think, has to be about being transparent, being willing to talk about failures, issues, problems, bringing that to the forefront to get others involved in the solution, and not just relying on that leader. So I think our past has been a real drag to that, but our future, I think, looks bright because, the younger folks that I work with now, that's just not where they live. They don't have that history. They expect to have a voice. They expect to be, to know what's going on. So I think all of those things are taking us to a better place where we have a more distributed leadership, more distributed knowledge base. And as we all know, two heads are better than one. And as we grow our teams to all be rowing in the same direction, work together, I think we'll be in a better place.
Thanks, Bob. Carol?
Yeah, I was going to say a couple of the barriers that I see are fear and exhaustion. So if you're fearful of being vulnerable, if you're fearful of saying the wrong thing or doing the wrong thing, that leads you to hold it in. And again, the opposite of that is a culture where people invite that. They're curious about what your voice is. And so it's a whole different feeling. And then the exhaustion part of it comes in that I know that when I feel exhausted, I'm not at my best. I don't frame things in the best way. So again, that keeps us from being our true authentic selves. And I think, again, the antidote to that is showing it to each other. When I know that often I would go into one of our executives' offices or even on a call and just say, hey, how are you doing? And so often they'd be surprised at that question. They say, nobody ever asks me that. I think that's how we chip away at this fear or this exhaustion and start to build each other up.
Thanks, Carol.
Yeah, so I was gonna say fear, and Carol, you just kind of hit that one out of the park. Let me start here. On walk rounds at a big system that I work with, we would ask frontline care teams about their day. What is your patient safety concern? And on one particular walk rounds, there was a young nurse, and I said, well, how's the work? Do you have any patient safety concerns? And there's a team of executives on the unit. And she said, no, everything's fine. I love my work. Which is typically, unfortunately, all too often what leaders want to hear. They want to hear good news. So I made it a habit of when the team walked off, I went back to her and I said, so, okay, now tell me how you really feel.
Mm.
And that's when, again, tears started to roll. She said, I've been out of nursing school and working for 6 months, and I'm beginning to think I never should have been a nurse. I said, why? And she's crying, standing at one of these computers on wheels. And she said, I have a patient down there who is in pain, but I'm told that I have to put this stuff in this computer so that some other person can be discharged by 11 o'clock. I became a nurse to help people feel better. I can't do that here. So we end up in these systems taking something from people. And as I define it, when I came to the decision point about my career, was when the CEO said to me, no money, no margin, no margin, no, the saying. And I said to him, this was over 10 years ago, where we're gonna go with this. If you don't have a mission, you're not gonna have a margin. Um, so we need to begin to think about how we deliver on what our mission is, and we all have these mission vision statements. Underneath those, the question is, do we love what we do? Do we love our community? Do we love the people that come through this door? Do we love the care teams out on the units? I walk up to a person in environmental services at the same system. That same question: how are you doing? What's your job like? Tell me what's on your mind. And he said, I love my job. And I said, good. Now tell me how you really feel. And he stood there and he said, I have never called out sick in X number of years. No matter what the weather is, I come to work. I love my job. I just wish that sometime someone would say to me, thank you. That's all I need. So we began to think that somehow we need balloons dropping out of the ceiling or a brass band marching down the hallway. We don't. Because just to say thank you to a person may be the only thank you they get that day. And I said that to when I was in practice to my care team, the people I work with in my practice. For some people, we're the first ray of hope when they walk through the door that day. We're the last line of hope when people come in seeking care and respect when they leave us. So no matter what the production pressures are, no matter what you think you have to get done, because somewhere someone has said to you, no margin, no mission. We're here for the very few people that come in to see us, because guess what? Most people don't come into a doctor's office for the hundreds of millions of people in this country. But when they come in, it may be the only smiling face, back to your point, Carol. It may be the only thank you. It may be the only I care about you that they get. We don't know where they are, but we make assumptions. And when you start to make assumptions about where people are, you have already failed them. You've already taken their dignity from them. And we fear that. Back to Carol's point, we fear that. We fear saying, I care about you. We fear saying, I love you. We fear the person that's going to tell us something that maybe we don't want to hear, especially leaders. Don't bring me any bad news, just bring me good news. Again, or they say, we have a policy that'll take care of that. Or they'll say, we have technology that'll fix it, right? That's not what people want. People want service. They want to be cared for. They want to be respected. They don't want to feel like, I'm nothing more than a binary digit in Cerner or Epic. And again, that's what the young man said. I don't have a physician. I have an accountant. He doesn't look at me. And when that and a friend of mine was on that particular visit, now hush, when she asked this physician about the visit and why he spent more time in the electronic health record than he did with the person sitting in front of him, his response, and this is what happens when we begin to over medicalize care. It happens when you go from medical school to residency. We lose something that we got to gain again. He said to my friend, There are thousands of people out here just like him. He was a 30-something-year-old black man who was paraplegic from a car accident. He said, there are thousands of people out here just like him. Why do you care so much about him? That means you've lost your sacred mission. And what I say to people quite bluntly is if you've drifted that far from your sacred mission, go do something else because you're hurting people. We stand and take an oath to first do no harm. If I love you, am I going to intentionally hurt you? Am I just going to say you're just another number on my appointment page? Am I going to say it doesn't matter to me that you're homeless or that you're the victim of domestic abuse? I've had a woman sit in front of me and say, let me just stay here for a while because my husband threatened to kill me on the way to your office. I'm safe here. We are in a safe, sacred place for people, and we may be that last string of hope that they have for that day. And I could go on, Richard, but
I
we've
love it,
talked
man.
about it.
And the
So we
chat,
got to get back to, yeah. Thank you so much.
you guys are firing up the chat. I want to be we could go on for hours. I want to be respectful of everyone's time. I'm actually going to shift us, I think, a little to the chat. There's a great call out, and I think it kind of maybe it rolls into one more question. But there's a question in the chat, Ron, which is, and I'll throw this out to all of you, Carol, and to Bob too. But the question is kind of seeking your thoughts on what is called, digital therapeutics. The patients are almost being prescribed apps for their care, and the question is, where's the love in that? And then you'll love the fact, Ron, that someone's telling tell the patient that feels like their doctor's an accountant to go tell the accountant to go figure. And then there's a winky face. So do with that what you want. But kind of as we move into we continue to move into a digital age, where's the love in an app, or is there a space in loving leadership in healthcare for technology? I kind of throw that out to you all. Bob, I know you've got some telehealth.
Okay, well, honestly, I'm not sure about the prescribing an app piece, but when we think about telehealth, I think that's just a way to make connection, right? So if we're using it as a way to make connection, and within that connection, we share our concern and are able to listen well and listen for understanding well, then I'm all for it. It's about making it easier to have healthcare access for some people, not for others. But it takes some work to be connected and on video, right? Like this. It's taken us some time over the last several months to get good at this. So I do think it takes some work and effort and perhaps some practice and some different techniques so that that caring can be communicated well in this kind of environment. But definitely it's here to stay.
Yeah, as evidenced by Bob trying to recruit you to be her doctor, Ron. She's feeling the love.
Feeling it.
So it can be done, right? Carol, you got a thought?
Yeah, several months ago, I did leadership rounds virtually. And our question, so there was somebody in person, there was a physician in person with the patient, and I was participating virtually. And the whole segment was on how people feel about virtual visits and talking to their doctor or others, on over a screen. And it was so interesting because, and this probably is no surprise to anyone, some people loved it and some people hated it. And so I think it's so important. The people that loved it talked about the convenience of it. They talked about having that opportunity to have a one-on-one conversation with their physician where nobody else was around and their physician wasn't typing. They were looking at them on this screen and it was totally at their convenience and the accessibility was great. And other people said, I just don't like it because it's too hard for me to do. But to me, that says two things. Number one, again, we've got to meet people where they are. We've got to be aware of and responsive to what works for people. And secondly, and Barb, I think you just kind of alluded to this and mentioned it, is that you can show the love through a video chat, just like there can be an absence of love in a person to person in-person meeting. So that isn't, the vehicle isn't what's important. It's
Right.
what we do with that and how we let that person know that we care about them.
Ryan, you have a thought about technology, telehealth?
So yeah, I think both Barb and Carol said it well. My first thought is when we move into telecare, telehealth, virtual health, we're not going back. So artificial intelligence, machine learning, robotics are here to stay, and will continue to advance, and we will learn from it. What I will say though is, as the old saying goes, every system is perfectly designed to get the results that it gets. So when we move into telecare, and the other old saying is, don't do anything to me without me. So as very smart people began to design algorithms, we need to make sure there's not embedded bias. We need to make sure that with intent, people and communities are brought into the design, a co-design of these telecare systems. We need to make sure that we bring experts to the table that know about community health, that know about population health, that know how you can reach elderly poor people, that know how we can bring telecare to people that live in tents that are homeless. So I think we have to bring the communities into this and make sure that the systems will allow the caregiver to make the best decisions with people, not without people. So that would be my concern, that we could, in essence, make disparities and inequity worse if we don't do it in a very thoughtful, inclusive way. So that would be the first place. And then continue to monitor and study the systems to see where the gaps are, and address those gaps. For instance, is bandwidth a problem? Can people afford bandwidth? What about, people that they can only provide an audio visit versus a video visit? So there's so much here to think about, that we can narrow disparities, but we can make them worse. And we have to think about that. Back to Carol's point, which is a really good one. You know when someone cares about you. It could be face to face, or it could be where we are right now. Body language, tone, posture. To Barbara's point, are they doing something else while they're on a call with you? So people are going to pick up on all those cues, and they need to be trained in, for medical students, residents, uh, uh, current physicians, and other caregivers. That needs to be trained in, so that you don't pick up on, people don't pick up on cues that this person is not listening to me. They don't care about me. They're off doing something else. And at the same time, though, we have to think about care for the caregiver. And I was on a call about this with a few months back, and there was a person who'd been doing telecare, and he talked about how he missed just talking with colleagues. And he just said out loud, he said, there are some days when I'm depressed because I'm sitting in this room talking to my patients. I can't talk to my colleagues the way I would talk down the hallway, or in the corridor in the hospital. So care for the people, but also care for the caregiver. I think we have to design into these telecare and digital health systems.
I love it. And I'm going to pick on something that you called out, and it's the theme of what we've been talking about today. Each of you has touched on it. I just want to say thank you, guys. We're going to switch to have Sarah see if we've got. I want to say see if we've got some questions. I know we've got questions, but have Sarah kind of moderate and see what questions we've got in the chat. Throw those out to the panel. I just want to say, if I don't get a chance before we hang up, because I don't know how technology works that well, Ron, Bob, Carol, I love you guys, and thank you so much for sharing today. But I know you've got a ton of questions out there, so I'm actually going to have Sarah moderate a little and see if we can get some questions to the panel as we wind down this phenomenally insightful time together.
Perfect. Thank you. Yes, what an awesome discussion. So Jewel asked, and I think this is a great question, how do we measure or sense love? How do we know it's happening or not?
So I'm going to try because indirectly, um, um, but where we're headed in healthcare, and we're actually already there, is value-based care. And one of the domains in value-based care is people and community engagement. One of the questions that I used, when I was at a couple healthcare systems, was one question I think is a robust HCAHPS question. How likely are you to recommend this facility? And look at those scores. And additionally, we as leaders, we need to look at what people are actually saying in the narrative, because it begins to tell you why they don't want to come back to you. And we pick up on those words. Some systems are fortunate enough to have natural language processing, but I would read through them, and you would pick up words like disrespect, like rude, like the place isn't clean, it's too noisy. You pick up on these as signals, and all too often in leadership, we think they're somehow anomalies. They're not. They are people telling you how they feel. And then we need to demonstrably act on those signals that come into us and not oversimplify them or, in fact, just dismiss them. So that's one place that now every healthcare system that receives CMS funding and has to do HCAHPS, that's one of the questions you're going to look at. What is physician communication? What is nurse communication? That is data that you can look at. Is the place clean? So those are things that's going to tell you how much leadership in a system cares about people that come into systems. And that goes for either inpatient or ambulatory settings. So that's one place you can look. Look at climate surveys that you give out to the workforce. One question that I look at in a hospital or a healthcare system: how likely are you to recommend this place to your friends or family, or would you come here for care? And look at that number and see what it tells you. And if you got a significant number of respondees and they're saying, I don't want to receive care here, nor do I want my family and friends to come here, leadership, how are you going to dismiss that? Maybe leaders do, but I would urge you to say, okay, now I need to go and understand this a bit more, because these are truly signals. Because people out on the units, whether they're work teams or people and families that come to us, they know. Yeah, and I call it the known unknowns. Is this they know, but leaders don't know because leaders don't want to know. So then that goes to the next level, what I call the unknown unknowns. And that's where true leaders will go down deep in the dark, cold water, way down under the iceberg to say what is actually down here. It's cold and it's dark, but I need to apply systems thinking to this so that we can provide better care for the people that come to us.
Thank you. That's so helpful. I'm going to switch gears to a question from Anna. And this is going back to the conversation around showing vulnerability. The culture within medicine generally is counter to showing vulnerability. How do we move towards changing that so providers are less burned out? Any
I would
thoughts?
answer that by saying it starts with each and every one of us. We have to show it, and then that is how it's accepted, and other people will then show it. We have to be the first to say, I'm going to love, I'm going to show that love to others. And I just think it's the accountability of each and every one of us.
Thank you, Carol. I'm gonna,
Poonam,
sorry, hold on one second. We have a question from Poonam, who just asked, how is the involvement of patient and family engagement improving patient care, especially during the pandemic and with the use of telehealth? Barb, I'll call on you. I know that's been an area.
You know, I was looking at that question and I was thinking, I'm not sure that we've had the benefit of having the patient and family as involved in the care during the pandemic because, you know, we've had restrictions on visitation. And so folks who might usually be at bedside supporting someone, they're not there. I mean, we've seen horrible examples of people dying alone with, you know, video conferencing or having a voice connection only. So I think what it has done though is it's highlighted the need. It's highlighted how important it is that we do involve the family in patients' care, that we do have that wraparound support for them, because it's critical for recovery. You know, most people don't recover in the hospital. There's recovery afterwards. It's critical. It's basic, you know, critical for that patient's survival. So I think, unfortunately, during the pandemic, it's been a bad outcome of the pandemic. But as we recognize that, I hope we'll work harder to include families as we move forward.
I agree. And I think it really is critical, as Ron pointed out, that we listen. We can't just have them say or be involved in things without really hearing their words and doing something about it. And I love when Ron asks the question again of people, so that if they said, oh, everything's fine, he didn't just accept that. He said, tell me more, or tell me how you're really feeling, or what can I do for you? That's when people open up. And so we do have to continue to involve patients and families in everything that we do in healthcare, and we have to listen to what they say.
Thank you. So one last question, and then we'll go ahead and wrap it up for the day. But from Tony, do you think love and care comes in when we use the communication of choice? So we are respecting and listening to their preferences. And I think we could apply this to both employees, caregivers, and patients. Thoughts on that?
I think it's a way of showing respect if we ask and respond to the way they want to communicate. As I said earlier, I think some people love one form of communication and others are uncomfortable with it. So we've got to be aware of it. It's a way of showing not only respect, but it is a way of showing that we care about them.
I think Ron framed it when he said, you know, channeling is in a Don Berwick when he said, you know, nothing to me without me. It's like, you have to meet people where they're at. We have to, and like Ron said, you know, it's easy to say, you know, how are you? I'm fine. But to go back and Ron's picking up on something there. He's picking up on a nonverbal. He's picking up on a power dimension that might be off. You know, a group of executives doing rounding is not typically the most welcoming environment to be, you know, vulnerable to yourself and communicating. So to look back and pick up on, so meet folks where they're at, figure out the forms and the channels they choose to communicate, and why they might not feel comfortable communicating in certain ways. That's our responsibility as, you know, in this kind of, as Ron reminded us, in this kind of sacred place of this sacred mission is to help folks, you know, communicate in a way that's comfortable for them.
Thank you, Richard. And thank you to each of those, a virtual round of applause for all of the insights that you have shared today. We appreciate it so much. And thank you for the engagement from our attendees. So many wonderful stories, insights, all of that to really allow us to think about this as we move forward. We did want to quickly share, so to the point made earlier that our people can't give what they haven't received themselves. We are hosting a conference this fall, XLearn, and it will be about how do we design those experiences so that whether it's learning and development or you know, getting people aligned to our mission and vision, the experiences that truly connect with their head, heart, and hands so that they can have the mindset, skill sets, and knowledge to do what they need to do. And so if you are interested, early bird registration for that goes through the end of this month. And lastly, again, we will be sending out the recording. If you have any questions about any of the content today, any challenges you're facing, our team is always happy to connect. And once again, thank you for joining.